I would like to invite Dr. MARIAN PAULY ma'am. She's the oculoplasty consultant at Giridhar Eye Hospital, and she'll be talking about superior limbic keratoconjunctivitis. Over to you, ma'am.
Good morning, all. At the outset, let me thank Dr. Sugaranjani for giving me this opportunity. Actually, I'm going to speak about SLKC, that is superior limbic keratoconjunctivitis. It is primarily the summary of what we have heard from all the other three talks. Slide. So basically, I'm speaking about my approach and the treatment protocol. As we know, it's a disease of unknown etiology where we can see there's a papillary reaction of the upper tarsal conjunctiva. Then there is inflammation and redundancy of upper bulbar conjunctiva. So that is very, very important. That is inflammation plus redundancy, because in there is, you can get confused with conjunctiva chelosis. In conjunctiva chelosis, the whole conjunctiva is loose. Then there are various staining patterns. Then superior limbal thickening. You can see the limbus thickening. Then superficial punctate keratitis of the upper cornea and filaments at the superior limbus or upper cornea. So basically here there are three components, that is tarsus, then bulbar conjunctiva, limbus and cornea, superior cornea. Coming to the risk factors, females more prone. Thyroid disease, which I would like to stress. In fact, the studies show 50% of SLKC can have thyroid disease. When the patient presents to an ophthalmologist, they are coming for chronic ocular surface irritation. So they will never say history of dysthyroidism, hyper, whatever. So it's always our responsibility to specifically ask them, are you taking any thyroid medicines or have you been treated for thyroid? Most of the time, what I have seen is they have taken thyroid medications, but practically they have stopped. So again, they've gone for hypo or hyper. Then dry eye disease, then ocular GVHD, then conjunctiva chelosis, then contact lens, chronic contact lens wearers, and various eyelid disorders. The most common is in ptosis. Majority of the ptosis patients, they come with irritation, foreign body sensation. When you invert the lid and when you see the bulbar conjunctiva, we can have features of SLKC. Diagnosis is always clinical. That's the most important thing. When the patient presents to our OPD, we will just see the slit lamp, give lubricants and send them home. But always invert the upper tarsal conjunctiva and see the superior bulbar conjunctiva. When there is filaments, we will do everything. But the clinical examination is very, very important, and it is underdiagnosed or misdiagnosed, I don't know. Coming to the treatment part, so from the history, it can be dry, you will get confused with dry eye, but if you don't specifically look for SLKC, you might miss. So when will you treat? Asymptomatic SLK, no treatment is required, but you can see, despite chronic symptoms and recurrence should dictate the therapy for SLKC. The aim of the treatment is to reduce mechanical friction and ocular surface irritation. So there is a battalion of treatment modalities, medical, surgical, all the medicines in ophthalmology other than anti-glaucoma medications is used in all this treatment. Yeah, okay. So now we'll just go. What is the mechanism? Lubricants we are already using. Steroids also we are already using. Then this I'm not going into the details. Then bandage contact lens, botulinum toxin. Punctal occlusion part of dry eye, SLKC, cyclosporine, everything I have heard. We have heard from all the other speakers. Oral doxycycline also we have heard about it. It upregulates MMB, it counteracts MMB upregulation. So I will just share one of our study which which we have done in our institute. We basically studied all the thyroid eye disease patients. So in the 5-year data we had around 3 incidents of 3% in thyroid eye disease patients, and we had 7 patients. And the most funniest thing is they have got out of the 7, 5 were dysthyroid, that is either hyper or hypo, and all majority were bilateral. So this was the treatment modality which was used in our case. All the patients received lubricants and steroids. Then 1 patient received bandage contact lens, and 3 patients received N-acetylcysteine or cyclosporine. This will come later. And this is the most important thing. We have to really educate the patient, because this is not a disease, put drops, improve and disappear. Not like that. They can have multiple recurrences, and the disease will stay a very long time. Sometimes it will take 1 year to at least to settle, sometimes 3 months. So the main messages from our study is always gradually taper the steroids. Initially we try to taper weekly and see whether she is getting or recurrences. If getting recurrences, then taper very slowly over a period of 2 to 3 months. But we have to be very careful. We have to educate the patient. If the patient is not willing for follow-up, I mean, you have to be very careful with the starting low-dose steroids for long term, like 2 to 3 months. Second line in treatment is in putting bandage contact lens. We have already heard from Dr. Sukiranjani. Again, it needs lots of patient education. The N-acetylcysteine drops. This is very useful. N-acetylcysteine respiratory solution is available. That is 200 milligram per ml. That can be diluted with the artificial tears and that in to 10%. And that can be used 4 times per day for 2 to 3 months. So this is actually very useful. Found to be very useful in our study, and all the patients had thyroid eye disease also. Then cyclosporin, which is already been using. So once the medical therapy fails, like multiple recurrences, patient is not willing for follow-up, patient is not very keen on putting bandage contact lens, you can think about surgical therapy, but this also you have to educate them. This is not the endpoint, still they can get recurrences. So conjunctival resection with or without tissue graft, that is just resecting the conjunctiva of the superior bulbar conjunctiva. How it works, we know there's an abnormally elevated bulbar conjunctiva. It can cause a foreign body sensation and cause inadequate wetting of superior cornea by tear filling. So this, either you can cover that resected area with an amniotic membrane graft, or you can put an autograft also. Second is cauterization. This is the very useful procedure which everybody can do in our clinical practice. This is the thermal cauterization, around 30 to 50 burns to the superior bulbar conjunctiva between 10 to 2 o'clock, up to 8 millimeter posterior to the limbus. Here the mechanism is, it increases the vascularity, epithelial cell production and globular cell density, and decreases the redundancy of the conjunctiva and increases the conjunctival fixation to the sclera. So this procedure is a very minor procedure, can just a regular cautery is needed, it can be done under topical anesthesia. Cryo, liquid nitrogen cryo, again it creates a scar between the superior bulbar conjunctiva and tenon capsule and reduces the amount of abnormal conjunctiva. So these are the few things in nutshell. The main thing to conclude, main thing is what from my experience you have to really educate the patient, then identify the risk factors. Majority of the patients, 50% of SLKC will have thyroid eye disease. So you have to really look into the, even if the patient is euthyroid, you have like for TSH receptor antibodies. Sometimes the antibodies will be positive. Steroids, lubricants, the mainstay of treatment. Step up the therapy and bandage contact lens. Surgical option in multiple recurrences. Thank you so much.
Thank you for that wonderful talk, ma'am. I think what you highlighted about the TSH receptor antibody is very important. We get only the T3, T4 TSH and then dispose the patient saying you don't have a thyroid dysfunction. That's important. Any questions can be taken at this point for any of the speakers? Sir, you have a question?
I have a question for you. Actually, it's very interesting study that you have done ASOCT in the recurrent corneal erosion. Most of the time we are unable to do it because they are having pain, the inflamed. So at what point of time you are doing the ASOCT and
all the patient at presentation, sir. This particular study was done at presentation. Even most of them did have pain unless there was loose corneal epithelium flapping and they could not open their eyes at all. We did instill a drop of paracaine and we did the study. This was at presentation.
Okay. And haze regarding the burr polishing, I also
often... Yeah, I wanted to know your...
I also often see it in the literature, but now I think I started burr polishing only recently, but nearly 100 eyes I have done. I have not seen any haze. So initially I was little skeptical about doing it in the central cornea, but nowadays I am doing it in the central cornea. I am not seeing any haze for this thing. I don't know, but I also often read it in literature. Any other experience? And to Dr. Pragya, I was asking, like, are you using secretagogues really in clinical practice, or it's just in the theory thing?
So probably a lot of the Sjogren patients who are like borderline, oral secretagogues in the form of pilocarpine is something either the rheumatologist starts or sometimes we start. The main issue is tolerance because they have all these other parasymptomatic symptoms, like they have increased sweating and they have flushes. So that is the reason why some don't tolerate. But if we push them to kind of use it for a couple of weeks, then I've seen that the patients now tolerate it better, or I give them like probably a lesser dose, and then once they're used to it, it depends. The patient is a little comfortable, they don't want to take the pain. But if they have very severe aqueous deficiency, then they sometimes feel very happy about the tearing in the eye.
I have one question for Dr. Pragna, probably the last question. These IT professionals which come to us, I'm sure everybody wants to know, what do you tell them differently? Like,
So I just,
do they feel more satisfied to see the array of tests that they do? Does it like help them in their symptomatic relief?
So
what
it's
has your experience been?
So the tests actually are quite useful for us to show them some evidence. Otherwise, they're not very convinced. But we can definitely pick up everything on the clinical examination. But I just tell them, like, you can't just run 10 kilometers just in a day. So you can't also work 12 hours on a screen just in a day. You need to slowly build your stamina to tolerate screen. So keep taking breaks, do everything possible. And then, you know, spend a lot of chair time actually.
I think one other important part is sometimes on orthoptics evaluation in these patients. Sometimes they don't have dry eye, it is just the strain because of an orthoptics issue. So just that can make a difference.
That I think is a very important point. Somehow with the noise created, or I don't know if that's the kind of awareness, everybody labels their symptom as dry eye. So the first thing I generally ask in the clinic is, what do you think is dry eye? And half the patients get filtered out at that question only, because they're thinking of something else as dry eye.
Okay, I would like to thank all the speakers and the audience and the panelists for, for this wonderful session. Thank you so much. Thank you so much.